Hi, good morning. Um, Even though being on stage with the mic is not my favorite thing, it is an honor to be here, to be with you, to learn from you, and to share about what San Francisco is doing for the ending the epidemics planning process. So we're going to give a brief overview, and we are excited to have this opportunity to develop collective strategies for HIV, hepatitis C, and other sexually transmitted infections so that we can further integrate our care and prevention services. And so San Francisco has really seen some great progress, but there are many communities that experience really significant and persistent health disparities and that are due to structural racism and economic inequality, and things are definitely getting worse. And so we know in order to get to zero and end the epidemics, we have to address certain cross-cutting themes. And these include homelessness and housing instability, mental health and substance use, access to treatment, prevention, engagement, and retention, and also incarceration. And we're also going to have a lot of planning conversations around the workforce development and retention issues, especially considering San Francisco is a very, very expensive city to live in. Oh, there's a nice visual. We are building on work that's already been done. So there are a lot of existing planning groups and initiatives, including the HIV Prevention Planning Council, the San Francisco Getting to Zero Consortium, NHEP CSF, STD Prevention and Control, and the Black African American Health Initiative, and the Drug User Health Initiative. So all of these existing groups are collaborating on this effort, and they all have their own strategic plans and directions. And so we have been working closely with the wonderful Vicente Consulting, and for the draft, they synthesize the existing plans into our draft so that we have a starting place that brings together everything that's currently happening, things we're proposing, and that also has a lot of input already from the community so that we don't go back and ask the same questions again, but build on this work. So we do have an Ending the Epidemic Steering Committee that has DPH staff, community-based staff, and some community representatives. And we're hoping that that will be the backbone to a really community-led process. So like I said, we have community engagement strategies and get input, but our methods are not working and they're not successful, and we have to change what we're doing and go beyond surveys and advisory groups, etc. So we're putting out the majority of the 1906 funding to bid to the community so that community groups and agencies and individuals that have really deep connections with the communities can then lead the engagement process and develop an advisory process where we bring our recommendations and then we get feedback. We don't participate in those meetings, and we pay people in a meaningful way for their time and expertise. And based on prevalence and health outcome disparities, these are really our focus groups in San Francisco. So Black and African Americans, Latinos, Latinas, Latinx communities, trans women, people who use drugs, people experiencing homelessness, and people with experience of incarceration. Now Bill is going to talk about our strategies.
Hello, it's great to be here this afternoon, well, soon to be this afternoon. We actually thought we were going to be coming to something that was similar to the previous state office ETE meeting where there'd be like, Post-its and papers, and so hope you'll hang with us here as it's a little more formal. So I'm also going to borrow from some of my colleagues and go a tiny bit off the script here. This slide we were asked to kind of identify a game changer. And so I'll just take this to be on the bully pulpit here and say a couple of things. It actually isn't us. It's larger than us, but we need to be a part of it. The first thing is to end the epidemic, we have to keep people alive. So I think we really need to have overdose prevention. Safe sites, also known as safer injection sites. We're losing a couple, 3 people every day on the streets of San Francisco, and the number of them that are homeless keeps going up year after year. So if we want to end the epidemic, the first thing is to keep them alive. The second thing I think has already been touched on here hugely, which is the housing. And it really was inspiring and exciting to see all the work that the federal folks are doing. What I would say, and we need to push, is that we need to scale up the funding for the housing, because we spend a phenomenal number of money trying to help folks because they're not stably housed. And if you look at our statistics, well, I'm down to 3, the housing status is 3 times more predictive than any other way we cut it. It's more predictive than your age, your gender, your race, your gender identity. So again, a push for that. And now I'll go back on on the subject of this here. So these are the game changers. Actually, advance this, see it. I'm going to move another slide in the interest of time here. So as you guys know, those of you on the care side or the Ryan White side, in the interest of getting stuff out, we had kind of a little more than 2.5 months to come up with the plans and spend the money. So what we did was 2 of us spent literally a month interviewing upwards of 10 people a week, our interviews to get subject matter experts. And these are kind of, we decided we wanted to spend all the money and do everything we possibly could, focused on the populations that Hanna identified. So I've kind of organized them to you here kind of in themes that we looked at addressing those populations. And in the interest of time, I won't deep dive into any of them, but in the questions, I'd be curious to hear what other jurisdictions did, but also happy to talk about it more. We were also asked to speak to opportunities for regional coordination. So you guys are probably aware the AIDS 2020 conference is happening in the United States. It's happening in both Oakland and San Francisco. And this has given us a lot of opportunity to coordinate with Alameda. And not only are we working on the conference, but it's a whole lot of other opportunities and expansions that we're looking at. And we certainly see the patterns about migration of San Francisco absolutely tell us that we need to be doing that. In terms of at a federal level on the care side, our collaboration is organized. Our EMA consists along the coast, so we're San Mateo, San Francisco, and Marin. So a lot of coordination both in care and prevention has happened there, but it doesn't, it's kind of a learning lesson in terms of populations going back and forth. We have a lot more to do with Alameda and Contra Costa than we do with our counties to the north and the south. So in terms of one of the stuff we're doing is we're also trying kind of on an informal level to work. You guys are probably aware there was a lot of excitement about the injectable long-term antiretrovirals, and there's kind of been a halt on that. We do have some hope that that may be a game changer, or at least something worth exploring. So we're going to be pulling them in and looking at our 2 systems. So we'll be doing some local meetings on that. In terms of CFAR grants, San Francisco, we got a total of 7, but 3 through CFAR, and 2 of them are also cross-jurisdictional. We're looking at lessons learned and improvement in San Francisco for regional rapid, getting people into care rapidly, and working with Alameda to see what we can do to support them, and maybe also to learn from them as well. And the second thing that we're doing is harmonizing, or rather a second CFAR grant is harmonizing data measures and collections both between San Francisco and Alameda. So, and finally, and my final thing is that we have actually included, we're in a meeting with also Contra Costa, Alameda, and San Francisco to look at regional stuff that we actually started for about 1.5 years ago, and that's just off the ground. And my final comment will be just the challenges that we're trying to overcome, and I think we have a lot of good ideas, is just the restriction on the different funding streams, and how do we make that at the end of the day that it doesn't matter to the person receiving the services.